So, welcome to the second episode of our menopause conversation. And today we're going to look further at the research coming out of Agile Life Sciences and more specifically, a deep dive into the MenoGuide reports. So, thank you for joining me today in conversation with Dr. Jan Rogers and Dr. Helen Keeney. So, thank you both for joining me. My name is Bethan Hughes and I work for Agile Life Sciences. And here today, we're here to look at MenoGuide and specifically the MenoGuide reports that we produce for clients when they've undergone their test. So, let's start with some introductions. Jan, would you like to introduce yourself, please?
Indeed, yep. So I'm Jan Rogers, the Joint CEO at Agile Life Sciences. And for the last 18 months to 2 years, we have been developing the MenoGuide test.
Brilliant. And Helen?
My name's Helen Keeney. I'm an NHS GP and I've also been helping Agile Life Sciences around the clinical aspects of a bit of advice and looking at the assessments for MenoGuide.
Brilliant. Thanks both. Before we get going, so we're just going to talk about the report and we're going to look firstly, Jan, at the three measurements that we report when we issue a MenoGuide test report. So if I could ask you to just walk us through the three main measurements and explain how we arrive at those measurements and kind of what they mean for somebody. Now, I know that's written in the report, but I think this will just be really useful for people.
Absolutely, yeah. And I think it's important to say that we use three measurements because there is little research in this area. So it's very difficult to go back and quantify and get exact readings. So we've taken three different variables and then we use all of those to make a judgment on where we think somebody is on their menopause journey. So the first one is the vaginal community state, CST. And that's a community state type. And what that means is what bacteria are dominant. So what community of bacteria have the dominance in that vaginal microbiome. And it really looks at predominantly lactobacilli. And I think we've talked previously about the different species of lactobacilli and how they are impacted on the reduction of estrogen. So the one that dominates premenopause is crispatus, Lactobacillus crispatus. So if there's greater than 50% crispatus, then it has a CST type 1, and then that is referenced as premenopausal. If there is greater than 50% Lactobacillus gasseri, then that is CST type 2 and likely to be perimenopausal. CST type 3 is greater than 50% of INAs, Lactobacillus INAs. That's also considered to be perimenopausal. And CST type 5, which is greater than 50% of Jensenii, sorry. That's also considered to be perimenopausal. So Lactobacillus, other than crispatus, generally tends to be more likely to be perimenopausal. CST type 4 is what we call dysbiotic, which basically means it's unbalanced. So there is no dominance of any one type of bacteria, but there are many types of bacteria there. So there could be 40% lactobacilli, 60% Gardnerella vaginalis. There could be lots of different bacteria types there. And they are typical of postmenopausal women. So that's the first measurement that we do. The second measurement we look at then is which of the lactobacilli are what we call endogenous, so created by the body, if you like, not added through yogurts or through any of probiotics. And we generically say if it's greater than 77% lactobacillus, which is very protective, prevents other bacteria from growing, then that's again healthy premenopausal. Between 45 and 75, so we're starting to see a drop in lactobacillus, then that's typically perimenopausal. Less than 45, it's typically postmenopausal because you're under that threshold. And then the third measurement is what we call the vaginal microbiome measurement. And this is our own developed sort of technology. And what we do is within that vaginal microbiome, there could be 100 different types of species. And we've quantified them all as either protective, so lactobacilli species, commensal, so kind of exist, don't really add or take away any value, and then there's kind of infection and pathogenic. And roughly we quantify if they're protective, they have a high score, commensal middle score, and infective poor score. We add all of those together, so we take how much is there and multiply it by the abundance. So what species is there, multiply it the abundance, and then we come up with a big number or a number. So that one number is actually very complex in nature to get. But again, what we say is if it's a higher number, so greater than 3.5 to 4, it's likely to be premenopausal, less than that number, perimenopausal, and less than 1, we would say is postmenopausal, quite dysbiotic. So we take those 3 measurements and we look at how many fall into pre, peri, or post. And typically, if it's 2 out of 3, if it's 3 out of 3, it's very clear. If it's 2 out of 3, then we take the dominant one. If we can't quantify it, you will see in some of the studies we've said unable to assign. And that's because at the moment we just don't know the research around that. So we don't want to be saying what it is. I think there's a clinical input, and I think that's very valid. But obviously what we're trying to do is make that a diagnostic. So we do say unable to assign in some of them. What we're hoping to do at the end of this study is have more clarity around our, the AI, machine learning, etc. So hopefully we will be able to assign those, but that's very much in the research phase.
Okay, so typically someone will get a CST score of 1 to 5 or unassigned, and we've just looked at the reasons for that. They'll get a native lactobacillus percentage, and then they will get what we call a VMM, which is their vaginal microbiome measurement. And that essentially concludes the laboratory part of the result within the report.
Exactly.
Okay, thanks, John. Okay, so Helen, we also include in the report a clinical judgment. And this is concluded from the questionnaire responses that somebody completed when they first registered to take the test. Could you just talk us through some of the, I guess, more critical elements to the questionnaire, and how you've kind of arrived at your clinical judgments? And also, if you can talk about some of the level of information that's provided and how that sort of helps and hinders you in your clinical assessments.
Yeah, it's a good question. I think it's probably worth addressing that first. So I think the questionnaire itself is relatively extensive, isn't it? It's quite a long questionnaire, but that's really been created for a valid reason, to get as much information from an individual as possible. So obviously we've got age there, we've got whether or not they're on hormone replacement or not, and then we move to the questions that we'd ask in a face-to-face consultation, things like how do you still have periods, have they changed in the last 6 months? What do you have any other particular symptoms? So we've separated them and included sort of symptoms around the sort of climacteric symptom checker, that type of score, around that. So lots of different aspects of both psychological and physical symptoms. And importantly, we've also asked around vaginal symptoms. So has there been any change in your, does it feel different down below? Do you have any new feelings of dryness? Has it been uncomfortable using a tampon for intercourse? And have you had any difficulties or treatment for that area? And that's really relevant and really important, isn't it, when we look at it? And then, so obviously, because it's quite an extensive questionnaire, how well filled in that has been really key. So when I've been looking at the clinical assessments, the more information, the better, like it would be if we were having a face-to-face and consultation. I guess the challenges around that is that, obviously you've got options to fill in a box, so we're not able to pad that out more than I may ask you a few more questions potentially if we were face-to-face. But actually, to be honest, a lot of the questions are, they're quite straightforward, and they give me a lot of information to be able to make a judgment with that snapshot of information. And that I think then is, we could chat about that maybe now, but from that I've been able to see with the information, is it pre, peri or post for an assessment.
Mm-hmm. Great, thank you. And I think we talked previously, didn't we, about some of the challenges that you have today in practice, in that you are reliant simply on, when a patient comes to see you, the reported symptoms that they're experiencing. So we've tried to reflect that in the questions that we ask, in order to kind of elicit that type of information from somebody. Okay. And then within the report, then we make an overall kind of conclusion based on all of that information. And we might include some signposting and some further advice, or recommend repeat testing, or seeing a consultation with your healthcare professional, or simply just, somebody might just choose to have the information, digest the information, and that might be enough. So there's a whole gamut of actions that somebody could take. Okay, so I think one of the things that we've noted through our conclusions is that we have seen, I would say, Jan, and correct me if I'm wrong here, a very high level of confirmation between the laboratory test and the clinical assessments. So we've seen high levels of, for example, somebody who comes out of the laboratory test is perimenopausal, and from the responses and Helen's judgment, equally perimenopausal. So we've got good synergy there that kind of concludes.
We got good correlation, and I think the correlations are very good. I think pre. I think we have good correlation. Post, and again we'll go through why there are some differences. Undoubtedly, the biggest challenge has been peri, and that's, I think, because of the diversity, the age, the age range, and all the other things. So, but we've certainly seen good correlation, as good as I think we're expected to see at this stage. There are some differences. I think we'll talk about some of those today.
Yeah.
And I think it's important as well that as we go forward, the research, the machine learning and things like that, where we can take all that information. So we're not just looking at the dominant bacteria, but we're looking at the very small amount of bacteria that are present. They could also be very key to be indicative as to where they are on that menopause stage. And to the human eye, it's just too much information for us to process, really. So, we really are relying upon the sort of the state of the computer, the computer age, the AI and the machine learning to be able to sort of really number crunch that. And I think that's a really exciting phase for us. But certainly, I think at the top level, we've definitely seen good correlation.
Great stuff. And when you refer to AI, you mean artificial intelligence?
I do indeed, yes. I had to think about that one. Yeah, artificial intelligence.
Yeah, so that's the big supercomputer kind of.
Yes, it can take all the massive amount of data, so all the, all the sort of the clinical symptoms and all of those things, all of the bacteria that we see, put it all in a melting pot and come up with some good correlations.
Yeah. So we might further down the line see perhaps a change in some of the conclusions that we're drawing from the data so far, which is really exciting. So we've alluded then to there are some differences. And I think it would be really, really useful for people listening and watching to perhaps for us to explore some of the reasons that we may think create that difference, and some in which we're fairly confident as to why the difference exists. So if we look initially at, for example, I've had my report and I'm reading through it, and I've got a clinical assessment of being premenopausal. And yet when I read on, then in my laboratory summary, I've got a diagnosis of being postmenopausal, or a conclusion, if you like. So can you just, both of you, explain perhaps how and why you've arrived at those conclusions and some of the reasons that may point to that difference?
I guess, Helen, do you want to start on how
so clinically pre, if they've not mentioned they've got any symptoms, they're still having regular periods and they're not on hormone replacement, I think automatically they would be classed as pre. Obviously, again, we're back to that questionnaire. It may or may not be fully filled out. So that's something that, if that has been, that we might get more information. But yeah, I would then label that as pre.
And I think this is probably the most challenging one, I think, because, it's from pre to post. It's kind of a big dichotomy.
And quite scary for somebody reading that report who
thinking, exactly
perhaps,
that.
I haven't thought for any moment that I am
menopausal.
menopausal in any way.
And all of a sudden I'm being told
I filled in a questionnaire and I've not ticked any of the boxes, and then I get this report that says, "Oh, good lord, I'm postmenopausal." So that could be quite overwhelming
hugely.
for somebody,
and quite impactful depending on where they are in their fertility journey, or
Absolutely, yeah. So I think from a lab perspective, why would we classify them as post, or why would we sort of put them as that? And remember, going back to those 3 measurements, two out of the 3 would say post. So it could be that they don't have a dominance of any one type of bacteria. So that would tend to be this type 4. So that would put them in post. It could be then that their lactobacilli is lower than 40%, and so they could have, and again, because we've developed this test, we do have to have cutoffs, and I think as we move forward, we're hoping they're not going to be quite so black and white, if I'm honest. But at the moment, our cutoff is greater than 50%. So if you're 49%, then you know what I mean. We would then say, well, we can't assign. Whereas 1% more, you might be able to assign it. So I think that's one of the challenges with the development of a test of this type. So not dominant by one particular bacteria. A low amount of lactobacillus, so not having a lot of protective bacteria. And then as a consequence of that, their vaginal microbiome measurement could be low, so less than 1. And it could be, for example, and you'll have seen on some of the reports, if they have a dominance of over 50%, then we say what that bacteria is. So they could just have bacterial vaginosis. So they could have Gardnerella prevotella at a 49%, which, and I guess, Helen, I mean, bacterial vaginosis is quite common.
It is common.
Premenopausal.
It is common, and for sexually active women, we do see quite a high level of bacterial vaginosis. And just to remind people, bacterial vaginosis is an overgrowth of a not sexually transmitted infection, and it just creates, for some women, this sort of thin, greyish, sort of can be quite smelly discharge for some women. It can just come and go throughout their cycle and be it's not necessarily something that you have to treat unless you have significant symptoms. But again, I think from our perspective for MenoGuide, it's having an impact on that report, isn't it? So.
Yeah, absolutely is, yeah. And I think, again, then you think about what can impact on your vaginal microbiome, and we come back to, feminine hygiene, don't use those products, I think we asked people to refrain from sex before sort of giving a sample, but sex will impact it as well, and so there are a few things that may well change that vaginal microbiome, and that's really, I think, why we've seen those differences.
So Helen, as a non-clinical person, some of the descriptors there for the bacterial vaginosis, could I be potentially thinking that I've got thrush?
Certainly some people describe itchiness. Yeah. I mean, it tends to not have the same typical discharge as thrush, because we tend to see a white sort of almost cottage cheese type discharge with thrush. But actually some women are self-treating bacterial vaginosis with thrush treatment over the counter, because that's what you can get hold of, over the counter. So
you might have symptoms. You might be using something like Canesten and it not go away. 100%. And that might be because it's not thrush. It could actually be.
And I think, although it's not necessarily giving you, that awareness of where you are in that transition with this result, this is useful information. And this information, if you're getting symptoms and maybe you're self-treating, it would be we'd signpost, wouldn't we, to potential treatments or further to get further information, if needed. So, yeah.
And for somebody in this case, that if they've had a report that indicates that, they are postmenopausal from a laboratory perspective, that there's been potentially a bacteria identified. If they then sought treatment for that bacteria, if it was causing them a problem, and then they were to have a retest in a perhaps 3 to 6 month window, we would anticipate a change in the laboratory diagnosis?
Yes. Yeah, we would expect it to go to a much more heavily dominated by Cris partus.
Okay.
And we've also talked, haven't we, around that if it is not necessarily an infected bacteria side, whether or not other aspects could be impacting on your vaginome. So things like lifestyle aspects as well. So just what were your thoughts around that, Jan? Because we've talked about this quite a lot, haven't we?
Yeah, I mean, smoking's a key one. And as we say, we've generally talked about vaginal health generally, but I think inflammatory markers, inflammation, all of those things can impact on your vaginal health. So I think it's kind of important to look at those. I think, like you say, Beth, and sort of try and manage those. So good, you'll know, I think it's good sleep, the 5 pillars of the lifestyle management. It's kind of good sleep, less stress, good nutrition, exercise, socialising, all of those things. They will impact on reduction on inflammation, which then will
absolutely.
improve
And I
that
think
vaginal microbiome.
we're not, that's why obviously the AI and all the big computer to look at all the data, because we have collected quite a lot of lifestyle data within that questionnaire, and I think we were quite keen to see if there were some associations there, because I think that's then helpful for women, isn't it, to think actually there are some real things that I can do here to help myself, and we're hoping it will help people feel empowered, I think, with their vaginal health.
Yeah. And some of the feedback that we've had thus far is where people have completed that section of the questionnaire, actually it's made them reflect on perhaps there are some things within their control or their gift, if you like, that they could potentially, take a look at. Maybe I could reduce my alcohol intake, try and get a little bit more sleep, all the things that we all try and do all of the time. Yeah. Okay, so if we move on then to look at another example of a report, and again, so let's look at somebody who's had a clinical diagnosis or assessment of being premenopausal. But when they open their report, the laboratory element would indicate perimenopause.
So again, I think from a lab perspective, that perimenopause is typically indicated by a different type of lactobacillus. So we start to see Iners, Gasseri, and Jensenii. And as they start to generate, they're formed because the pH is dropping slightly, which could be indicative of the estrogen dropping. So this may just be a disjoint, I guess, in not seeing symptoms yet, maybe close to getting symptoms. So I think from that perspective, we're starting to see a change in the lactobacilli. Still, what we would say very healthy in the fact that we've still got a lot of protective bacteria. So sort of between 45 and 75%, just a different type of the lactobacilli.
And it could be early, couldn't it? It could be the before symptoms, although 1 in 4 of us don't have symptoms. So is it that actually you're identifying the change for maybe women who may never actually experience symptoms, or who are only going to experience symptoms once it hits a much lower level of estrogen that obviously would be further down the line? So but
for the early stages, absolutely.
For these women, from my perspective from the clinical assessment, would be would have normal periods, not on HRT, and not reported any symptoms. So I would label them as pre, but this could really add value and more information, that both as a clinician and for the woman herself who doesn't have at that stage.
And the value potentially of doing a test 3 to 6 months later, to sort of just manage, am I still progressing through to menopause? Because then again, 6 months' time, that will either be more dominant, I guess, as perimenopausal, or it will have stayed the same basically.
And a great opportunity for lifestyle advice at that stage, because then that would be optimising your overall health and well-being, and then reducing that inflammatory factor and on those other things that could contribute to worsening hormonal health and symptoms.
Great. And was there any correlation in that group, Jan, around perhaps age or anything like that, or anything that stood out or not, or was it kind of
classic 40 to 50?
Right.
I think they were all sort of 40 to 50, I think. So, the classic perimenopausal age.
But I think it's really helpful, because this is the key, isn't it? That the clinical diagnosis is clinical, which is right. And you listen to all the symptoms and you hear all these different things. But women typically, obviously busy time of life, different pressures going on. A lot of those symptoms can be put down to different things. So this would add, certainly for me as a perimenopausal woman, it might add more information to say, actually, it's not just because I'm, got 2 teenage children and parents who need my support and all the rest of it. It would actually be, I maybe need to think of another dimension here. So I think this has got real potential, actually. And maybe clinically, for me as a clinician, thinking, I need to think menopause, which we ought to be doing,
And that, I think you're right, maybe allows the woman to stop and think, actually, have I just ignored all those symptoms? Because, we know we can fill in forms and just say, no, everything's fine. But then obviously somebody nudges you and you think, actually, maybe I have got some symptoms. So,
Brilliant. Thank you. Okay, so let's move on then from our clinical pre-diagnosis to look at clinical assessments of perimenopause. And flipping that on its head, we've got a laboratory assessment of premenopause. So from a clinical perspective, Helen, you've concluded perimenopause, and why might that be? I mean, clearly there would be a myriad of reasons, and we can't look at every individual, but what are some of the kind of standout features?
Some of the features would be a change in periods, obviously not necessarily driven solely, but a change in periods and an age. You know, obviously we'd start thinking perimenopause. Certainly if they've mentioned vaginal symptoms, dryness, and obviously if they'd filled in the symptom checker and they started to score higher on that, then we're starting to think actually these got quite a number of potential perimenopausal symptoms. So I think, you know, we know it's a combination and you don't have to have a change in periods to be perimenopausal. But for these women who I've been assigning, that's been kind of one of the key features.
Okay. Yeah, and I think from the lab perspective, we will have assigned them pre because they will have been dominant in crisparatus.
And the good guy.
That's the good guy, yeah.
Right.
And so, I mean, and it may be because they're on contraceptives. So contraceptives could influence
So if they're on the combined pill, they're
pill,
going to have estrogen on board. So that's going to be helping. It may not be enough to help with the perimenopausal symptoms, but it may be enough.
Yeah.
We'll find out, won't we?
Exactly.
Whether it'll be.
Yeah.
Yeah.
Yeah. So that's kind of one thing. And again, the other, there may be just be a disjoint in timing, which is, you know, we've identified them as pre, but they have seen some symptoms. And over time, we might actually see that the crisparatus converts into INAs and to Jensen iron gaceri.
And just, this is a question, and as we know that during the perimenopause, the estrogen levels are fluctuating quite considerably, how stable is the vaginal microbiome to be able to, because obviously blood tests are hopeless because that's no good from our perspective clinically, but the vaginal microbiome stays relatively...
Yes, so it responds to the drop in estrogen. So whilst that fluctuates up and down, it has to be a general downward trend because if, you know, the bacteria can't grow that quickly, basically, you know, they can't get all the mates in, you know, so the pH won't drop quite as significantly or overnight or even within the day, which is what happens with your hormones. So it has to be a general downward trend for the bacteria to change from crisparatus dominant to
because I think that's got a bit of potential to look at, because that's what's hard to identify, I think, clinically.
Yeah.
And I guess, Jan, we spoke previously about the kind of the 1% maybe tipping the balance. And I guess that's applicable here as well, in that somebody might just be just making one of the measurements for being premenopausal. Yeah,
and you know, I mean, absolutely. So let's take that whole vaginal community state, for example. They could be CST2, which we would instantly go perimenopausal, but then they have a lot of lactobacilli, so they could have 40% crisparatus, 60% of another one, and that takes the crisparatus, the lactobacilli measurement up, which says they're pre. And then as a consequence, of vaginal microbiome measurement is also a high score. So that also takes them up. So then we say, right, 2 out of the 3 have now said pre, but to your point, Beth, it's just finding that cusp. And I think that's why it's important to look at the other symptoms and the other bacteria that are present, particularly as we come to sort of doing the that whole AI machine learning, which will be massive.
And potentially, Jan, in time, we might be able to be, and I don't want to put words in your mouth here, but potentially more conclusive. So, you know, you are premenopausal, but you are at perhaps the peri end of the scale of premenopause, if that makes any sense.
Yeah. So I think we're kind of anticipating we will stop putting in these 3 boxes of pre, peri and post, and it will become more of a sort of a spectrum, if you like, so where they are on that spectrum. So entering perimenopause, exiting perimenopause. I think the challenge we have, and we may come on to that next, is postmenopause is quite definitive. I mean, so Helen, you can tell me how as a clinician you will say it's postmenopausal.
I mean, we'd say anyone's postmenopausal 12 months after the last period. I mean, and then that's it, you're classed as postmenopausal. However, as we know, if they're on hormone replacement or we don't know what their periods are, if they've got the Mirena coil or, you know, they've had a hysterectomy, then that makes it more challenging. So, but you're seeing that quite distinctively, aren't you, on the...
And I think we're starting to see, it's interesting because somebody may be, I mean, literally, I guess, theoretically, the last day of their last period, they're postmenopausal. But we just don't know when the last day of the last period is. So that's why there's this 12-month gap. I guess. But what we have seen is there has been a sort of a disparity, I think, in some where you've classed them as sort of peri and we've sort of said post. And they could be post because they may just never have another period.
But they haven't had the 12 months, so I'm not allowed to say
exactly,
it yet. Yeah, but like I say, that's come out of, that's just literally because we know that occasionally you can, your ovaries have just got one more kind of, go. And you see some people 2 or 3 months and then they start having periods again. So 12 months, you're very unlikely to have another period. So that's what we mark it at. But yours could make it more specific, couldn't it?
And I have read cases of women that have gone 350 days and then boom, out of nowhere, they've had a period. So technically...
Yeah, they'd be peri again.
There would be peri again. Whereas...
The likelihood is they're...
postmenopausal. Yeah. And just because somebody becomes postmenopausal, that doesn't mean then that all the symptoms stop overnight either, does it?
No. And it tends to be for that 3 to 5 years after those periods stop, you can get the most florid symptoms. So for a lot of women, that's the time where they are coming to seek help. But the likelihood is that perimenopausal stage of up to 7 to 10 years could have been happening before. So to identify it early, and we've mentioned before, that's key, isn't it, to try and help women with symptoms rather than it becoming a crisis or difficult at that stage.
But for some women, the cessation of periods is kind of the light bulb moment,
the trigger,
isn't it?
Yeah, absolutely.
I guess it's quite a challenge for women that are sort of postmenopausal, as in, so beyond the 12 months, to then think, I need HRT. Because I'm guessing most people think HRT is through the perimenopausal phase and HRT, you don't need it. But I don't know from a clinical point of view.
I think certainly you see a lot of women that say, I've finished my last period, there's a bit of relief. Certainly women who've had difficult periods, which they can get more difficult during the perimenopause. There's a sense of relief. And then actually you see people just saying, I've got through it. I've done it. I've managed. Yes. And then you think, and then they're starting to get worsening symptoms. So it can be quite tricky because then 2 or 3, 4 years down the line, post their last period, I'm seeing a lot of people go, can I have HRT? And actually, if women have got significant symptoms, there's certainly, as we see through that post-menopause time, quite significant vaginal symptoms, which can be the genitourinary and bladder symptoms. Genitourinary symptoms of menopause can become really key. I mean, I think we chatted yesterday, but the evidence out there is 80% of women in their post-menopause will have symptoms, either vaginal or urinary symptoms, and a lot of women just put up with them. And I think we chatted, it was that 8% come and get treatment. I mean, if something could help you and help these women get some treatment early, because a lot of the times they're coming because they've had recurrent urinary tract infections and they've had some women who've put up with the most unbelievable soreness and not being able to sit, not being able to wear trousers, not being able to do their job. Just generally, women generally are quite tough and keep going, but it would be great to catch these women early before they start getting infections and things like that.
Definitely.
Okay, great. Thank you. So I think there we touched on the clinical peri-diagnosis and potentially the differences. From a laboratory perspective, would there be a difference, Jan, from whether somebody was on or off or not taking HRT rather? So would that provide a difference from a laboratory perspective, would you think?
I think so. And I think, again, I'll talk in generic terms. There's always the odd one that sort of bucks the trend. But I think in generic terms, we've seen particularly postmenopausal women that have been on HRT, they have a much higher amount of lactobacillus crispatus, and sometimes Jensenii and Gasseri as well. They have a much higher level of lactobacillus, so a much greater amount of protective bacteria against those that are not on HRT. And I think there's a clear definitive between those that are and those that aren't. So yes, I think it's fair to say that that's an accurate statement that we can definitely see. And I guess what we'd like to think, and again, Helen, your input's great, is the benefits then potentially of knowing you've got the right dose of HRT to make that a protective environment again is kind of, is where we'd like to get to.
Absolutely, because at the moment we've got standard dosing from a vaginal estrogen perspective. So we've got a licensed dose of, how you use. Tends to be 2 weeks of using vaginal estrogen, then twice weekly to keep on top of it. But you do see women still describing symptoms, but obviously a lot of clinicians not feeling confident about going maybe beyond that to try and treat symptoms, which is quite relatively safe to do so. But for, I think this could add a more individualized approach to women's vaginal and potentially systemic health if they're on systemic HRT as well. And we know that 1 in 4 women need vaginal estrogen as well as systemic estrogen. Maybe this could help possibly show that, if you're still getting vaginal symptoms and you're on HRT, is it that you need to titrate up the HRT, or is it that actually you need some vaginal estrogen as well, which could help complement the HRT for you as an individual to treat your symptoms? It's got that potential, I guess.
Yeah, no, absolutely.
So I think one of the things that I'm taking away from this discussion is that women shouldn't settle. So you shouldn't be settling if you are perhaps at the latter stages of your menopause journey. Don't settle for symptoms that you've perhaps lived with for what feels like an eternity. And similarly, if you've been able to have a HRT prescription, that again, if you're still having symptoms, it might be potentially that the method of delivery isn't right for you. That's one of the things that I've gleaned recently.
Absolutely. And I think it is, so individual. So a lot of the times we start women on hormone replacement and then we review it at 3 months. And then obviously if everything's okay at that stage, we and especially, with the cost of prescriptions, we tend to say, and here's a year prescription, which is great. But actually, if you're in the perimenopause, your symptoms are changing. And obviously through the whole transition, your symptoms will change and you'll have different needs. So it could be that the more systemic hot flushes, palpitations, or those symptoms start settling. But then your vaginal symptoms or urinary symptoms become more of a feature. So yeah, absolutely. Bespoking it to the individual is key. And not having a regular review and trusting yourself that if it's not right and doesn't feel right, go back and have a chat.
Yeah. Brilliant.
I think that's the key, isn't it? If it doesn't feel right, go back and have the chat. I think is one of the key, isn't it?
One of the other things that I've read recently is around HRT, is the fact that some people see an impact of that HRT different time frames. Is that quite common?
It is quite common. So I've got a couple of ladies that within 1 to 2 weeks, they see improvements in their sleep. They feel their anxiety levels are improving. Hot flushes can improve. But actually, and then that's consistent, and then it really improves and they think it's the best thing ever. And then some people who start on it and actually there's maybe not even that many sort of improvements. In fact, you can get some of the side effect impact, which can really put people off, the breast tenderness, nausea, headache, and that's the sort of estrogen effect. But actually at 3 to 6 months, they really start seeing improvements. And that might be, we need to either start a dose slightly lower and titrate up gradually, or we need to increase the dose if people are just not getting symptoms and not that many side effects. So yeah, it's really individual. And actually both estrogen is really noticeable for that and the delivery method. So I've got some women who we've done blood test as a snapshot. The only time to do a blood test really would to see if they're absorbing, and they're on a maximum dose of patch and the estrogen are in the boots. And you just think it must just be their way their skin is and how they're responding to the patch. So change it to the gel or spray, and that's key. But yeah, I think that's the thing, isn't it? I say to most women I see, we will get this sorted, but it's going to take a year and we're going to have to work together, and you need to let me know. And, and again, like you said, Beth, don't settle. Like, let's just track your symptoms, consider that lifestyle element. What can we do to, what can you do for self-care? Think about all those different elements and then get that prescription right. So for women who do want to and are able to take HRT, I think it's a good solution for many. But like I say, there's quite a lot of other facets around menopause, that menopause transition, that I think we feel really key, that this, hopefully a lot of the data that we'll get will help empower women around different areas around nutrition and activity and things like that as well.
And I do think sort of, a test is kind of, again, it's objective data. And I think that's the key to it. So it's kind of, along with, it's important to know how they feel and if symptoms are improving, et cetera, or not improving. But then also if you've got a set of objective data, it gives you that clarity and that confidence to say, actually, you need more, or, actually this seems to be working. It perhaps just needs a little bit more time.
Brilliant. Thank you. Okay, final one that I'd like us to examine today would be, we have a clinical diagnosis of postmenopause. And yet we've got a laboratory assessment of premenopause. So again, where we started the conversation today, is flipping it completely on its head. So Helen, we've touched on this already, but please, don't hesitate to repeat yourself. So we've got a clinical assessment of postmenopause.
So it will be over a year from the last period, and age will have an impact on that. So, that would be taken into consideration. And if women have said that they've got any significant vaginal symptoms or menopausal symptoms. But I think key for me there would be age and periods.
Okay. And Jan?
I think so again, if they're premenopausal, they are going to have a high level of Lactobacillus crispatus. And I would say that's typically dominated by if they're on HRT or not. And so if they're on HRT, then that would explain, I think, why we see this anomaly between post and pre. So post from clinical.
So I've diagnosed them as post because of all the clinical data, but they've been on HRT and that's improved their microbiome into a pre-state.
Yeah, and so basically it's a protective state. So we talk about UTIs and things like that. Then they're dominant in lactobacilli, which is a protective bacteria, and so a lot healthier down there.
And that's the sort
of
holy grail.
Yeah,
I was going to say exactly. So that's the aim for postmenopause. So would those women then be, we would expect, a lot less risk of urinary tract infections, probably, hopefully have a more comfortable, vagina generally. So, intercourse, being able to sit and ride a bike and do all those things that you should do.
Things.
Yes, absolutely. Yeah.
I do have to say that we did have one lady, 62, postmenopause, not on any HRT, almost dominant, 97% lactobacillus crispatus. Amazing.
Yes.
It's a complete anomaly, but just amazing.
I want to look at her lifestyle.
We absolutely
and we all need to.
We absolutely need to go and find that lady and find her lifestyle, because it will be really interesting.
Yeah.
But that would be really interesting, wouldn't it? Because if we can see there's some features through that would be great to study, wouldn't it? Because we're all for lifestyle medicine, but I think that would be pretty good study.
Yeah.
Yeah.
And I guess some of the other people that you've talked about might be a combination that they're on HRT, but they also live I was going to say Zen lifestyle, but perhaps have low stress, low levels of inflammation, manage life very well. And, that's not to say that it's impossible for many, but I think, we have to be realistic as well in terms of
modern life stresses and all the rest of it. Yeah, absolutely.
40 to 55 is a stressful time, isn't it? There's so much going on, like kids growing up, jobs are getting, you're doing a lot of work, you're trying to multitask a million times at a million miles an hour. I'd like to think maybe as we get to 60, 65, things are coming down.
Jan's going for goals. But I think if I had an objective test, I wonder if at that stage it might just allow me just to think about because a lot of the time when I'm seeing patients one-to-one and even talking to groups of people, it's about actually we're rubbish at that time of life of prioritising self-care. So is that an opportunity and another reminder, a bit like when you have your blood pressure taken and it's high and then you go, oh, maybe I need to stop adding salt and I need to start doing my exercise and all the rest of it. We know that when we're in a clinical consultation room, that's quite an impactful conversation. And we know that lifestyle, it's important for us to talk about lifestyle with patients because that's key. And then is this going to help add to that? I just wonder. I think that would be brilliant.
Like you say, just a little nudge to, a little bit of me time, a little bit of just thinking about it. Yeah.
Well, watch this space.
Indeed.
Great. Thank you both.
Thank you.
So if you'd like to learn more about the work of Agile Life Sciences, you can find out more on our website. So the MenoGuide website is www.menoguide.co.uk. We also have some social channels. So MenoGuide UK on Facebook. We are Agile_LS on Twitter and Agile Life Sciences on LinkedIn. So that's where we share lots of our updates and our ongoing work and more about our research. And please do visit the website regularly because there's always new content appearing there. Thank you.